Welcome to a new video from Hospitalista channel where we teach you how to comfortably handle all different kinds of inpatient clinical and non-clinical problems. Today we are going to finish analgesia and sedation in mechanically ventilated patients. A link to the first part video is provided in the description field, so make sure to watch that first. Also make sure to check the ICU crash course playlist that this video belongs to. A lot of topics have been explained already in that playlist. A link to the playlist is also provided in the description field. I have 15 multiple choice questions to cover analgesia and sedation in mechanically ventilated patients. I will provide a quick explanation after each question. By the end of this video, you should be able to handle most of the clinically encountered issues when providing analgesia and sedation in mechanically ventilated patients. It will also help you answer any board-related questions in this topic. Before we start, remember to hit that subscribe button and notification bell to stay up to date with our channel content as soon as they are released. Let's go. The correct answer, of course, is B. Always make sure your patients are adequately resuscitated with IV fluid before starting analgesia and or sedation. Otherwise, they may become profoundly hypotensive once placed on mechanical ventilation. In such case, if their blood pressure dropped once placed on the ventilator and no signs of fluid overload, and here I'm specifically talking about signs of pulmonary edema and JVD, just give them 1 to 2 liters of an isotonic solution, and most of the time that will get their blood pressure quickly up. Please try not to use vasopressors until your patient is adequately resuscitated with IV fluid. Now, for option A, a central line is not always necessary, and starting analgesia or sedation should not be delayed until a central line placed. For option C, stable oxygenation has nothing to do with starting analgesia or sedation in intubated patients. Now, how about option D? We should never start paralytics unless our patient is adequately sedated first. Remember that very well. Let's go to question number 2. Of course, the answer is B, which is false. Most patients will not require any additional sedation for the next 20 to 30 minutes after intubation, as medications used in the procedure still linger in their system. But if the patient was looking uncomfortable, we definitely can start analgesia and sedation earlier. This means we have time to pick the right agents for our patients and to resuscitate patient with IV fluid if required. Let's see what question 3. The correct answer, of course, is B. We almost always use analgesia first and then add sedation if required. We should never or try to refrain from starting a pure sedative medication without providing any analgesia first. Let's move to question number 4. Of course, this is true. Daily awakening trial is better and has been linked to a 2 days decrease in the time the patient spent on the ventilator. In general, the as-needed approach or the daily awakening trial approach are the preferred ways to administer analgesia and sedation in mechanically ventilated patients. Let's go to question number 5. So let's remember that the main use of analgesia and sedation in intubated patients is to relieve their pain, fear, and anxiety from being on the ventilator. If the patient is already severely obtunded, then he's having none of that. Analgesia and sedation is not required in such case, and the correct answer is D. Now, if the patient started to wake up, getting uncomfortable and not ready for extubation yet, only then we should start analgesia and sedation. Let's move to question number 6. Of course, the correct answer here is C. Fentanyl is the preferred initial agent to provide analgesia and sedation in mechanically ventilated patients. IV opioids in general are equally efficacious, but fentanyl has a less hypotensive effect and no significant metabolites that can accumulate in patients with hepatic or renal impairments. Unlike morphine and hydromorphone, which can have metabolites that can accumulate to harmful levels in those patients. Now, ketamine is not FDA approved for use in adults in ICU. Sometimes it is used off-label for procedural sedation, extreme agitation, as an adjunct to opioid analgesia. It has some analgesic and bronchodilator properties. That's why some may use it in intubated asthmatics, but again, it's all off-label use, so don't pick it on board exams. Let's go to question number 7. Now the best or the correct answer is C. We almost always start with analgesia and more specifically with analgesic sedative agents, an agent that provides both analgesia and sedation. And as we just explained in the previous question, fentanyl is the preferred analgesic sedative medication to start with, then add actually Propofol or precedex if more sedation is necessary. Please try to avoid using benzodiazepines if possible, as they may be associated with longer days of mechanical ventilation. Let's go to question number 8. Of course, we just mentioned the previous question. The correct answer is D. Benzodiazepines are thought to be associated with longer days on the ventilator. They can cause prolonged sedation as well, up to days even after discontinuing the sedation, especially in elderly patients and those with hepatic or renal impairments. So please don't rush to do further neurological workup in such patients. Just give them time to wake up and avoid further sedation, of course. Now, Propofol, precedex, and fentanyl all have a variable degree of quick onset and offset effect. That's why we like them. Let's go to question number 9. Now, I want you to pay attention here. Paralyzed patients need a deeper level of sedation. Neither fentanyl nor precedex can provide the desired level of sedation in such patients. Propofol or midazolam have to be added in such patients to provide that level of sedation on top of fentanyl and precedex. Again, patients are different. Of course, option B and C are preferred in paralyzed patients. Well, in the ventilator, option D still can be used. We still can use a benzodiazepine, but again, we try to avoid benzodiazepine if possible. Let's go to question number 10, and I hope you scored 9 out of 9 so far. Precedex can cause a paradoxical effect on blood pressure and heart rate. So either can cause hypotension or hypertension, bradycardia or tachycardia. All can happen, especially if a loading dose of precedex is given. Now, hypotension and bradycardia are more common and can be profound and persist even after precedex discontinuation. That's why it is recommended, and remember this, it's recommended to avoid precedex loading dose if possible. Let's go to question number 11. The correct answer here is B. If mild sinus bradycardia developed while on precedex, we should try to slow down the precedex infusion. If bradycardia worsened, then discontinue precedex immediately. Remember that bradycardia may persist even after discontinuing precedex. Cases of high-grade AV block and even sinus arrest have been reported with precedex, so pay attention to that medications. Now, fentanyl can definitely cause bradycardia, but we cannot leave the patient without at least some analgesia and sedation, and precedex should be suspected first as the culprit agent, as we just mentioned in the previous question. Now, atropine can be given if profound bradycardia develop, and adding midazolam can be considered, but think about using propofol first if more sedation is still required. How about question 12? Let's see that question. Of course, propofol and precedex are the ones should be given as continuous infusion, while fentanyl and midazolam can be given intermittently as needed or as continuous infusion. And for dosing, I recommend you consult with your ICU pharmacist or use any of the pharmacology references. I did not mention them here because you don't have to memorize that. Just look it up. Let's go to question number 13. The correct answer here, of course, propofol. Hypertriglyceridemia and hypertriglyceridemia-induced acute pancreatitis can happen in patients receiving propofol infusion, especially higher doses. Triglyceride levels should be monitored in these patients and discontinue propofol if triglyceride level reach around 500. Let's go to question number 14. Propofol-related infusion syndrome is a rare but life-threatening complication of propofol when given in high doses, more than 60 mcg per kg per minute. If suspected, please stop propofol immediately and pick the answer on the board. This is not propylene glycol toxicity, which is a possible complication of Ativan drip use, but not midazolam, because propylene glycol is the solvent used to administer chlordiazepam and diazepam, but not midazolam. Propylene glycol toxicity is characterized by hyperosmolarity and increased anion gap metabolic acidosis, and patients receiving lorazepam drips should have their osmolar gap closely monitored and stop lorazepam if the osmolar gap more than 10. Now let's move to the last question. I hope you scored or you answered all the questions so far. The correct answer here, all of these medication can accumulate in those patients. As we explained, we should try to avoid using benzodiazepine as they may be associated with longer mechanical ventilation days and can cause prolonged sedation. In case benzodiazepines are required, let's say someone with seizure, as needed or PRN approach is definitely preferred over continuous infusions. Same apply for morphine and hydromorphone, specifically morphine. I don't see any reason really to use those medication over fentanyl in mechanically ventilated patients. Alright, that was the last question. I hope you found what you were looking for in this video. I'm positive it will help you answer any bore-related questions in this topic as well. Please drop me a comment with your opinion if you like this question styles videos or not. And for any questions or suggestions, please just drop me a comment. Thanks for watching and I'll see you next video.